Okay, so today we started a discussion about lung cancer. And when we look at this CT scan, you see that there's a obvious mass here on the right. Okay. And of course, the lecture is on lung cancer, but what other findings here would increase your suspicion for lung cancer in this patient?
Emphysema?
Right, so there's emphysema. What does that tell us?
Smoking history?
Right, so the patient is a smoker. Of course, that's a risk factor for lung cancer. What other risk factor does the patient have?
Coronary artery disease?
What?
CAD?
Coronary artery disease itself is not a risk factor for lung cancer.
Plaques?
Yeah, so there are calcified floor plaques. What does that tell us?
Asbestos?
Yeah, so that the patient has asbestos exposure. The most common neoplasm associated with asbestos exposure is no. The most common cancer associated with asbestos is lung cancer, not mesothelioma. Okay. So bronchogenic cancer, of course, smoking, asbestos, but any disease that causes extensive fibrosis in the lung can also increase the risk for lung cancer. TB, asbestosis, idiopathic pulmonary fibrosis, scleroderma, any fibrotic lung disease does increase the risk for lung cancer. In terms of the types of cancers, the most common is adenocarcinoma. Squamous cell is the second most common. Small cell, very aggressive, strongly associated with smoking. And then large cell anaplastic is another type of cancer that you might run across in terms of the pathologic descriptions. If I tell you that this lesion here is an adenocarcinoma, what do we think about this lesion here in the left lung? First of all, what are the characteristics of this lesion in the left lung? Yes, it's purely ground glass and it's rather small. Okay. So what do we think that might represent?
If we're saying they have a history of adenocarcinoma, I'm worried about lymph.
Certainly it is possible, right? So it could be a metastatic lesion, could be an inflammatory lesion, but there is another lesion that is very typically found in patients with cancer that can present as small ground glass attenuation nodules. What are those lesions?
It's pre-detections, like the atypical.
Atypical adenomatous hyperplasia, right. Those don't tend to grow. Those don't form into lung cancer, but they are a marker that the patient is at increased risk for lung cancer. So often in patients with lung cancer, there may be other foci of small ground glass attenuation nodules that are not necessarily metastases. These can represent areas of atypical adenomatous hyperplasia. So these are atypical proliferation here of cuboidal or columnar epithelial cells along the alveoli. They tend not to grow, so on follow-up CTs, they usually remain stable. So they don't transform into cancer, but they can be a marker that the patient is at increased risk, or we may find these in patients with lung cancer. So it's found in 10 to 23% of patients with lung cancer, maybe multiple, can be associated with synchronous malignancies elsewhere in the lung, atypical adenomatous hyperplasia, usually small ground glass attenuation nodule. So here we have a spiculated lesion with a central calcification. What are we worried about here? What might this be?
Cancer?
What kind?
It doesn't be adenocarcinoma.
So what are the features that make you think about adenocarcinoma here?
Spiculated
So what's that?
appearance.
All right, so it's a spiculated appearance, it's a nodule.
Central calcification.
Well, what could the calcification indicate? So,
Granuloma with transformation.
well, granulomas don't transform into cancer. You can have dystrophic calcifications within cancer, so cancer can have dystrophic calcifications, but cancers can occur next to granulomas, so-called scar carcinomas that can engulf granulomas. And the most common cell type of scar carcinoma is adenocarcinoma. All right, so the most common so carcinoma is associated with scarring that can engulf granulomas, tend to be adenocarcinomas. So adenocarcinoma is usually peripheral. Most common cell type in non-smokers also. So grows slowly but metastasizes early, so-called scar carcinoma. These can be associated with scarring. So here we have a chest radiograph that is unchanged for 6 weeks. What is the finding on the chest radiograph?
Consolidation is the number one.
Yeah, so we have consolidation in the left lower lobe. So I told you that it's unchanged for 6 weeks. What is your differential for chronic consolidation in the lung? What could that be? So you could have post-obstructive pneumonias, right? So one of the reasons that whenever we see pneumonia in a patient or we think it's pneumonia, on your initial chest radiograph, you recommend follow-up chest radiographs to resolution is because you don't want to miss a post-obstructive pneumonia. So certainly post-obstructive pneumonia might be in your differential, or it could be, or should be. What else is in your differential diagnosis for chronic consolidation? So eosinophilic pneumonias or chronic eosinophilic pneumonias can give you consolidations. Typically they are bilateral, right? Peripheral consolidation. So yeah, if you have peripheral consolidations, that can be in differential. This seems to be one. There doesn't seem to be any others, although I haven't shown you the entire right lung. What else is in your differential for chronic consolidation?
Bronchoalveolar carcinoma.
Yeah, so so-called bronchoalveolar carcinoma, although that term is no longer used. So what you want to say is what?
Differentiated adenocarcinoma?
Well differentiated or mucin producing if it presents as a consolidation like this, a mucin producing adenocarcinoma. What else can be in your differential? Actually, around here, we see this quite a lot. Patients who come in with consolidations, chronic consolidations, don't change over multiple chest radiographs. What disease does that? What infection? What infection gives you chronic consolidation?
TB.
What?
TB.
Tuberculosis, right. So certainly tuberculosis in your differential for chronic consolidation, chronic airspace disease. You mentioned peripheral consolidations. We can also see that with organizing pneumonia, of course. Fungal infections can also be associated with chronic consolidations. This particular patient, just a nondescript chronic consolidation in the lung that did turn out to be adenocarcinoma. There is another neoplasm, infiltrated neoplasm, of course, rarer than lung cancer, that can also present as chronic airspace disease in the lungs. What neoplasm is that? Seniors? Chronic infiltrative neoplasm, airspace disease in the lungs? You have bronchograms, what neoplasm? Lymphoma, sure. Especially non-Hodgkin's lymphoma, so that can also present as chronic airspace disease, although that's pretty rare. But this was bronchoalveolar carcinoma, term no longer used, subtype of adenocarcinoma, not associated with smoking, lipidic growth, air bronchograms, tracheobronchial spread. We'll talk about all that. It's mucin producing, so it can't produce bronchorrhea. So when you have consolidations in airspace disease, you can, if you're thinking about tumor, think about mucin producing tumor like that. Now this can also present as a solitary nodule, which is the most common presentation, consolidation, and multiple small irregular 5 to 6 millimeters nodules from spread through the airways, so acinar nodules from the airway spread. So here's one tumor here presenting as a nodule, but these can be multifocal, right? So these tumors can occur more than one area within the lung. So multifocal sites of tumor can also be associated with these cancers. When adenocarcinoma is associated with ground glass opacity, the ground glass tends to correlate with well-differentiated areas of the tumor, so it's a good prognostic indicator. So the greater extent of ground glass also correlates with improved prognosis. And the ground glass is caused by lipidic growth, meaning that the tumor grows along the alveolar sidewalls within the air spaces without destroying the underlying lung architecture. So when you do a CT scan in partial volume, all of this, you get ground glass instead of a solid appearance because there's still some air within the air spaces here. Other features that we can see, bubbly lucencies called pseudocavitation. So these may represent dilated bronchioles and expanded air spaces, but if we see bubbly lucencies within an area of ground glass opacity, that is a high-risk indicator, so there you do have to think about tumor, and again, that results from lipidic growth of the tumor without destruction of the airways. Another appearance is multiple nodules like this, but these are ill-defined nodules. These are acinar nodules, and it's caused by airway spread of the tumor when it disseminates through the airways. If you see a chest radiograph like this, what are some of the first things you're going to think about?
TB.
Yeah. Well, is that miliary TB, first of all? Why?
Multifocal pneumonia.
Yeah, so, and the bronchial spread of TB, bronchopneumonia, yes. So bronchogenic dissemination of infection is the first thing you're going to be thinking about. So some form of bronchopneumonia could be dissemination, airway dissemination, bronchogenic dissemination of TB or another infection, bronchopneumonia. So that's probably the first thing to think about if you see multiple nodular opacities like that that are kind of ill-defined airspace opacities. So these terms have been discontinued. So now the terms that are used for what used to be called BAC, adenocarcinoma, and what is the correlate of that on imaging, small solitary tumor, pure lipidic growth. So the correlate of that on imaging is less than or equal to 3 centimeter lesion, purely ground glass on CT, adenocarcinoma in situ. So if you have a ground glass opacity lesion, less than 3 centimeters, if we think it's tumor, that might be adenocarcinoma in situ. Minimally invasive adenocarcinoma here, there's predominant lipidic growth. Again, the tumor less than or equal to 3 centimeters with less than or equal to 5 millimeters of invasion. That's what the pathologist will see. What do we see on CT? We see a semi-solid appearance on CT, so it may have a small solid appearance. So these tumors have a very good prognosis, 100% survival after resection. So what do some of these things look like? Well, we talked about atypical adenomatous hyperplasia. If you have a ground glass attenuation nodule less than 5 millimeters and you think it's atypical cells, then likely to be atypical adenomatous hyperplasia. Again, these usually do not transform into cancer. If we have a ground glass attenuation lesion larger than that, but still less than or equal to 3 centimeters, and we think it's neoplasm, that might be, and the reason you follow these lesions with CT is you're worried about this, adenocarcinoma in situ, right? If we have a lesion that is still less than 3 centimeters overall, but there is a solid component, and that solid component is less than or equal to 5 millimeters, then we worry about MIA, minimally invasive adenocarcinoma. If the solid component is larger, but we still have ground glass, then lipidic predominant adenocarcinoma, non-mucinous. And then what was the classic appearance of BAC? Consolidation. We have consolidation, mucin-producing tumor, invasive mucinous adenocarcinoma. So all of these used to be called BAC, but this is the current terminology, and these are the CT correlates of what these lesions will look like. Okay, what's wrong with this chest radiograph?
Consolidation in the right.
We can do a little better than that.
It's more like the golden sign best.
So it's atelectasis.
Yeah, so there's right upper lobe atelectasis, and you said there's the golden S sign, so what makes you say there's the golden S sign?
Kind of an S.
There's a bulging in the fissure, right? So usually when you have right upper lobe collapse, the fissure should collapse against the mediastinum, but if there's any bulging in the fissure, then that is the golden S sign. So why is there a bulging in the fissure, and what are you concerned about?
Obstructive lesion.
Yeah, so you're worried about a centrally obstructing lesion, and in the lesion here, the central lesion is what does not allow the minor fissure to collapse against the mediastinum. So whenever you have atelectasis with displacement of a fissure, if there's a bulging in the fissure, you're going to worry about a mass and obstructive atelectasis. So, and this patient did have a tumor here. What do we think this tumor was?
Well, if it's large like that, it's probably going to be like a small cell.
Well, small cell is usually more aggressive and tends to be associated with extensive lymphadenopathy. This lesion is presenting with atelectasis, and it's involving the right upper lobe bronchus. So central lesion presenting with atelectasis, we're going to think about what?
Endobronchial.
So what lesion does that? What cell type?
Squamous.
Squamous cell, yeah. So this was a squamous cell cancer. So squamous cell cancers can present with obstruction, central lesions.
Dr. Malcolm,
Yep.
Does that central necrosis also help you say it's squamous as well, with the hypodensity centrally? Or is that
Well, the hypodensity centrally, it's hard to say whether that's necrosis or not. I mean, it would help if we had a contrast with it, but you can't see necrotic nodes. So we're going to get to another feature of squamous cell that can also be seen, but the type of nodes that you see with squamous cell in the neck, those low attenuation nodes with peripheral enhancement, we can see that in the chest also. So when you have lymph nodes with central low attenuation, that can also be associated with squamous cell cancers. What's wrong with this case? Okay, so why do you think there's right lower lobe atelectasis?
Loss of the right hemidiaphragm.
Okay, so the loss of the right hemidiaphragm, what do you think of the position of the right hilum?
Downward displacement.
Yeah, so here's the left hilum will be here, here's the right hilum will be here. Looks like it's displaced downward, volume loss in the lower lobe, loss of the right diaphragm. So you're concerned about right lower lobe atelectasis. Is that it, or is there more? Do we see the right heart border?
No.
What are we thinking about that? Middle mediastinal obscuring the right heart border? When we have obscuration of the right heart border, where do we localize the pathology to? Right middle lobe. Does that help? So we're losing the diaphragm, we're losing the right heart border. We think there's volume loss?
Yes.
Yes. So what's collapsed?
Lower and middle.
Okay, so combined atelectasis of the right middle lobe and the right lower lobe, what would do that? Right, obstructing lesion in the bronchus intermedius. Also, when you compare the right lung to the left lung, what do you notice?
Or hyperexpanded.
Okay, so the right lung is more lucent than the left lung, and you interpret that as what?
Hyperexpansion.
Of?
The right upper lobe.
Yeah, so compensatory hyperinflation of the right upper lobe when we have collapse of the right middle lobe and the right lower lobe. So if there's volume loss, so this is a pearl, remember this, because you're going to see this a lot on your portable chest radiograph. If there's volume loss in the right heart border, if you have volume loss with loss of the right heart border and loss of the diaphragm on your chest radiograph, you're going to think of combined atelectasis of the right middle lobe and the right lower lobe, and we would localize the obstruction to the bronchus intermedius. And indeed, there is a lesion there in the bronchus intermedius. What is our differential diagnosis here? First of all, the most common thing in the bronchus intermedius that's going to cause collapse would be what?
Mucus plug?
Mucus plug, right. Do we think that's a mucus plug? Why not?
Pretty solid.
That's right. So what's different about it? That why do you vote against mucus plug? Because yeah, the attenuation, right? The attenuation is not the attenuation of fluid. Usually mucus plugs, especially one that large, would have fluid attenuation. So you don't like mucus plugs. So what is your differential then? Actually, before we get to that, let's talk about this. Here's your atelectasis of the right middle lobe. Here's the atelectasis of the right lower lobe. What are these low attenuation things? What are those? Yeah, so that's mucus plugging of the small airways because there's obstruction here. So the secretions can't get out. So you're looking at mucus plugging here of the small distal airways. When we compare the right lung to the left, notice that right lung here is more lucent than the left lung because
Compensatory.
yeah, so there's compensatory hyperinflation. This is all right upper lobe. There's compensatory hyperinflation here of the right upper lobe when we have collapse of the right middle lobe and the right lower lobe. Back to our differential. What is our differential for this?
Endobronchial lesion.
Well, okay, so let's go through differential of endobronchial lesion. You want to say, do you like carcinoid, yes or no?
I mean, it's not common.
So, yeah, carcinoid though does belong in your differential for an endobronchial lesion. But what's a typical feature of carcinoid that this does not seem to demonstrate?
Oh, it has.
Right. So carcinoid tends to be a very vascular tumor with marked enhancement, right? So you would like to see that. We don't have that here, but still going to include it in your differential, right? Carcinoid tumor, maybe the patient didn't read the book. So carcinoid tumor, of course. What else?
Squamous cell.
Yes, squamous cell cancer, right? That's an endobronchial lesion, endobronchial neoplasm. And then there are a couple rare endobronchial neoplasms that you might also include in your differential. What are they?
I mean, there are some mets that have.
Okay, there are tumors that have a propensity to metastasize to the airways, right? Although usually in those cases it's known that the patient has the tumor. But what are those tumors?
Laryngeal.
Yeah, so head and neck tumors can spread down to the airways. Any head and neck tumor, what else? Well, of course, lung cancer can also, breast, right? Breast a good choice, what else?
Laryngeal and thyroid.
Thyroid, yes, thyroid's a good choice, yes. Renal cell also can do that. And whenever there's metastatic disease to an unusual location, a nice tumor to include in your differential is
Melanoma.
melanoma, of course, right? You would include that also if you're talking about metastatic lesions to the airways. But back to primary tumors of the airways, what are some more unusual primary tumors of the airways that can present as an endobronchial neoplasm? They tend to arise from salivary glands. Adenoid cystic and mucoepidermoid tumors, right? So those also can give you endobronchial lesions. Adenoid cystic, though, tends to occur in the trachea. Mucoepidermoid tumors tend to occur in the more distal airways. So here, probably squamous cell and carcinoid might be the first things on your differential. These small nodules here, what do they represent? Is that metastatic disease? See these small nodules?
Tree and bud.
Yeah, little tree and buddish. So what do you think that's from?
Probably it's maybe aspiration.
Yeah, so a patient, it's bronchiolitis. So a patient has some bronchiolitic changes here. There's an obstruction here, maybe coughing, maybe a little aspiration. So that looks like bronchiolitis. Okay. All right. What do we think of this one?
Oh, it's not white out.
Well, it's not quite whiteout. Whiteout is complete opacification of the hemithorax, but there is a large opacity there in the left hemithorax, right? So how do you interpret that? What is the opacity?
Is that the left lower lobe?
What?
Left lower lobe, since there's the apex?
There is some aeration here,
Would that
right?
full sign?
Okay, so what are you thinking about?
I mean, then it would have to be, much like Dr. was saying, it might be like a left lower lobe obstruction of some sort.
Well, what is, first of all, the loop sickle sign is a plain film finding associated with what underlying pathology?
Atelectasis?
Of,
Left lobe.
see, correct?
Left upper.
Left upper lobe, all right? If, first of all, is there volume loss? Do we think there's atelectasis?
No,
Well, what are you going to look for to decide if there's atelectasis?
the high line,
Hylo, what else would you look at?
Diaphragm.
the fissures.
Yeah, you're not going to see the major fissure on the left. You don't have a minor fissure on the left, so that's probably not going to help you. What about the mediastinum?
Mm.
I got an here from Dante, so.
Can't see the heart.
There's another one. Yeah, where's the right heart border? All right, so trachea may also be slightly displaced, but certainly we don't see the right heart border where we should see it. Okay, so is there evidence of volume loss? Yeah, there is evidence of volume loss. Okay, so if you think that's the loop sickle sign, how do you interpret it then? Volume loss where?
I mean, it's not so, I mean, in this case, it's probably not.
Well, let's see if additional films help us. There's a lateral view. I got another somebody me over there. What's the finding on the lateral view?
It seems like it's left upper lobe that's
Okay. What is this? See that?
Pleura.
That's, how do you interpret that? What is that? Is that a normal finding on the lateral view? So what does that represent? It's a major fissure. What side? Left side, meaning what? There's left upper lobe atelectasis. This is the major fissure on the left side. All this opacity anterior to it is a collapsed left upper lobe. So indeed, this is a loop sickle sign from left upper lobe collapse. So what causes the loop sickle sign when you have left upper lobe atelectasis?
I mean, it's the interface of the aorta and the left lower.
What part of the left lobe?
The
Superior
superior.
segment. So you get compensatory hyperinflation of the superior segment of the left lower lobe. That can become border forming with the aortic knob. So when you have opacity like that and you think it's atelectasis, we see the loop sickle is German for air sickle, so you see an air sickle like that adjacent to the aortic knob. So you could be dealing with left upper lobe collapse with compensatory hyperinflation of the superior segment of the left lower lobe. So this patient has a big nasty tumor, and where'd he go? Land, here you go. Here's your nice example of low attenuation within the tumor. What kind of tumor is this?
Squamp.
Huh?
Squamp. Squamous.
Squamous cell, right. This is another squamous cell cancer causing obstruction of the left upper lobe bronchus. And then here we have our compensatory hyperinflation from the superior segment of the left lower lobe, giving you the loose sickle sign. Okay. Now in this case, this is complete whiteout. In this case, the mediastinum is shifted. So this is complete left lung collapse. And if we look at the airway, we can see kind of an abrupt cutoff in the airway here. So there's obstruction of the left main bronchus. And then here's what it looks like on CT. What would you like to see after this? First of all, what do we see here?
Cut off.
Yeah, there's an abrupt cutoff of the left main bronchus. So what's the problem? What's this patient's problem? Can you tell?
Nice to have contrast.
That's right, it would be nice to have contrast. There's your contrast. So what do we see now? Yeah. Well, you can see the endobronchial component of a tumor. We can see that this area over here, so the left pulmonary artery, there's also mass effect on that. And this area over here does not enhance as much as the periphery of the lung. So this is a diffuse infiltrating neoplasm in the periphery here. These are regions of atelectasis. So the point is, again, the bigger the abnormality on the chest radiograph, the more important it is to give contrast if you want to figure out what's going on. So do not accept a non-contrast CT from the ER if they want to do that. If you have a very large abnormality on the chest radiograph, always do it with contrast. It's very difficult to differentiate atelectasis from tumor on a non-contrast CT. Much easier when we give contrast. And then here's a nice correlate with the PET scan where you can see the tumor. This is the tumor here on the PET scan. You can see the endobronchial component, and it correlates very nicely with the CT. So the CT does help you differentiate with contrast, when you do a CT with contrast, between the infiltrating tumor here and the region of atelectasis. Be careful because was this done as a PE protocol? No, right. The pulmonary arteries are not very bright. So a PE protocol might not help you. Why?
It's arterial phase, not
Yeah, it's
venous
the
phase.
pulmonary arterial phase, right? So it's not the venous phase. So PE protocols tend to scan early. That's before there's given time for, sometimes you do get enhancement, and we've seen enhancement of the lung, atelectasis and stuff with the PE protocol. But you're much better off doing it as a routine chest CT where there is more of a delay to give time for the enhancement of all the vessels and the differentiation between the atelectatic lung and the tumor itself. Okay, so the PE protocol is not the optimal way to image a lung cancer. Another example, right upper lobe atelectasis. You can see the cutoff of the right upper lobe bronchus on the coronal view and the axial view. Again, it's hard to say what's going on the non-contrast CT, but when you give contrast, now we can see the blood vessels here. We can see this lower attenuation region here, which represents the tumor itself. So now we can differentiate the tumor from the atelectatic lung. So it's much easier to figure out what's going on when you have atelectasis, when you give contrast. Okay, what's wrong with this chest radiograph? Anything? Anything on the left side?
Flattening of the left lower.
Well, a little obscuration here, but you can see the blood vessels through it, so that could easily be a fat pad.
The left mid lung.
Okay, in the left mid-lung here, there seems to be some funny looking opacity. So let's take a close-up of that, right? So what can we say about it?
No. In terms of its contours, it's largely, let's say, it's well-defined contours mostly. And it's a little heterogeneous
Yeah, it is somewhat heterogeneous, right? So there are these areas here that maybe look a little bit less dense than the remainder of it. So here's the CT, so what is it that we're looking at then?
Cavitary lesion.
Yeah, so you're looking at a cavitary lesion, right? So your differential for a cavitary lesion in the lung would be what? Hmm? What kind of cancer? Yeah, so squamous cell cancer is the cancer associated with cavitation, right? What else would give you cavitary lesion in? Vasculitis, what else? Septic emboli, necrotizing pneumonia, fungal infections, right? So any infection might cavitate, okay? So for this, I mean, given the topic of the lecture, but what are reasons why you would favor cancer in this case as opposed to what?
The thickness of the line, when it's greater than 15 millimeters, it's typically more.
So the thicker the wall, the more you're concerned you're going to be about malignancy. What about the edges of this thing?
They're speculated.
Yeah, it's spiculated, right? So you have these spiculated borders around it. So that's another reason why you should be concerned about this, right? So that turns out to be a squamous cell cancer. So cavitary lesions, right? Squamous cell cancer can present as cavitary lesion within the lung. And as you said, the thicker the border, the more you're concerned about malignancy. Here's another squamous cell cancer, very thick border, lots of soft tissue here along the border. This patient also has pretty extensive mediastinal lymphadenopathy, so cancer really has to be at the top of your list in this case, especially if you think the patient's a smoker. Okay. So squamous cell cancer can be endobronchial, can be peripheral, most common cell type to cavitate, grows rapidly, metastasizes late, paraneoplastic syndrome, hypercalcemia from ectopic parathermal, right? So those are the things to know about squamous cell cancer. What's wrong with this chest X-ray? Bobby, come on, there's an obvious problem here.
Right upper lobe opacity.
All right, this is big. You're going to call that an opacity or something else?
Mass.
Yeah, there's a big mass here, right? Kind of paratracheal, large mass. So what do you think that might represent? Yeah, so it certainly could be lymphadenopathy, right? The most common cause of a paratracheal mass might be lymphadenopathy, so you're certainly concerned about that. Of course, we are here discussing lung cancer, so, well, first of all, your differential for lymphadenopathy is what? What's your differential for lymphadenopathy? Lung cancer, what else?
Sarcoid.
Is that a good, who said sarcoid? Who said that? Who said that?
Not in this case.
Is that,
Not in this case.
why not?
It's only one station.
Well, sarcoid tends to present with hilar, symmetric hilar nodes. You do not like this appearance for sarcoid, okay? So what else is in your differential for lymphadenopathy? Well, we can do better than lung cancer. What else?
TB.
Yeah, okay, so it could be post-infectious. Certainly TB might do it. What else? Sure, right, lymphoma, metastatic disease from anything, right? Can't present as lymphadenopathy. So those are certainly things to think about in your differential. Is there another finding on the chest radiograph?
Is the mass like, yeah, the trachea is like moving into the trachea?
Where's the trachea? Okay. Yeah, it looks like the trachea is in here somewhere, but. All right, let's go through the exercise. What's the list of things you look at on your chest radiographs? Lines and tubes, next.
Airways.
Airways, right, trachea, maybe a little defined. What else?
Mediastinum.
Mediastinum, okay, what else?
Bones.
Bones, what do you think of the bones?
There's a left rib that's like fully out.
Yeah, this whole rib is missing, right? Okay, so how do you interpret that? From what? Well, you have if you have what looks like a tumor here and a bone is missing, right? Metastatic disease, right? So certainly now we're really thinking about cancer. So here we go. There is all of that stuff. Here is the soft tissue mass in the rib, causing the rib to be missing. So what kind of tumor do we think this is? Yeah. What, again, the topic is lung cancer, right? So what squamous cell maybe? What is this big white thing over here?
It's a calcified node.
Is that calcified
The
node?
SVC.
What?
Behind the SVC.
Is that the SVC? What is that? Somebody say. Come on, speak up. That's the azygous vein. Why is it so big and dense?
Oh, is this, it's compressing the SVC.
What?
It's compressing the SVC.
Do you see the SVC?
You know, not really.
Not really. So this patient has what? SVC syndrome. Okay, so that's a collateral because the SVC is squashed. The most common neoplasm, we're talking about lung cancer associated with SVC syndrome is, no, not Pancoast. No, not adeno. The most common lung cancer associated with SVC syndrome is small cell lung cancer. Small cell lung, very aggressive, tends to present as central tumor because of the extensive mediastinal lymphadenopathy. It's very aggressive, can obstruct the superior vena cava. So strongest association with smoking, very aggressive tumor, most common to cause SVC syndrome, other paraneoplastic syndromes, Cushing's, SIADH, Eaton-Lambert syndrome, central mass with extensive lymphadenopathy. So we have right paratracheal nodes, left paratracheal nodes, big left pleural effusion, extensive mediastinal lymphadenopathy, big pleural effusion, another example of small cell lung cancer in this particular case. SVC syndrome, obstruction of the SVC, here's some collaterals. So whenever we see collaterals along the chest wall, whenever you see the azygous vein is bright and dilated, look for central venous obstruction. Here the SVC is obstruction. And small cell cancer is the most common lung cancer to do that. Another type of tumor we might run across, large cell anaplastic carcinoma. There's nothing really specific about the imaging appearance of this. These tend to be aggressive, large lesions, usually larger than 4 centimeters. You might come across large cell neuroendocrine cancer when you look at the histology or the pathology reports of some of your lung cancers here. High-grade, poorly differentiated neuroendocrine tumor. So it makes up about 3% of non-small cell lung cancers. For whatever reason, I'm starting to see a lot more of these than I used to. I don't know if it's because pathology is better at classifying the tumors or not. Okay, what's wrong with this chest radiograph? Right, so there's asymmetric here, right apical pleural thickening. Compare the right side to the left side. So what are we thinking about? Pancoast tumor, right. You have apical opacity like that, and we're dealing with a talk on lung cancer. We're going to think about Pancoast tumor. What makes you say, when you look at the CT, well, this is a Pancoast tumor?
It's invading the adjacent rib.
Yeah, the rib is destroyed. You have an apical mass with rib destruction, so this is neoplastic, okay? So the first thing you want to think about is neoplasm, and if it's at the apex of the lung, then we call that Pancoast tumor. So it's also called superior sulcus tumor, which is the groove for the subclavian artery, Pancoast syndrome, arm pain and tingling, and ulnar nerve distribution, Horner syndrome. It's due to the apical tumor invading the brachial plexus and sympathetic chain. It can be any cell type, most commonly adenocarcinoma. In Pancoast's original description, superior sulcus tumor, pain in the arm, ipsilateral Horner syndrome, destruction of bone and atrophy of the hand muscles. Apical mass, asymmetric pleural thickening, bone destruction. So if we see asymmetric apical pleural thickening, look carefully at the bones on your chest radiograph. You may not actually see the bone destruction on chest radiograph, but sometimes you might. And if we look on imaging, apical mass with bone destruction, here it's invading the vertebral body. So that is the appearance of a Pancoast tumor. Okay, is this a Pancoast tumor?
No, that's not.
So how do you know?
There's like the reticulations due to it. It looks like there's volume loss.
Yeah, so it looks like there's volume loss. You can see the trachea is deviated to that side. What about the right hilum? Where's the right hilum? Yeah, the right hilum is elevated. Are there changes in the left apex?
Yeah, that's probably the placebo. Right?
Yeah, there's some reticularity here in the left apex too, so there's some abnormality there, but the trachea is deviated, the hilum's elevated, so that looks like volume loss. These lucent areas represent what?
Articulation of the honeycomb.
They're more central, so how about bronchiectasis? Okay, so if this is not Pancoast tumor, what is this then?
Fibrosis.
From?
Radiation.
Radiation bilateral?
Probably FSC.
And so certainly one thing you might, I mean, radiation is not a bad choice. It's, you know, for right upper lobe cancer, it is conceivable you might have some spillover on the left side. But around here in this hospital, TB, right, this is tuberculosis, right? This is scarring from tuberculosis in this particular patient, okay? So all of these changes here in the right apex, this, and there's also some changes on the left side. This was a patient with tuberculosis. Okay. So here we have a mass, and the question is this approachable by bronchoscopy, or are we going to have poor Sultan stick a needle in this and get another big pneumothorax?
I think Sultan might have to go.
So what are you going to look for to decide if it's approachable by bronchoscopy?
This is adjacent to a bronchial.
Okay, so is there an airway that goes into it, or is there an endobronchial component, right? And if there is, you have to be able to describe which airway to tell the bronchoscopist where to go. So what do we think? First of all, what lobe is it in?
Right lobe.
It's in the right lower lobe. Okay, so when we look at the airways here of the right lower lobe, this guy here, there's an endobronchial component and it's going right to the lesion, and you can see the little endobronchial component, right? So somebody said that was the medial basal segment, right? That's the medial basal segment, medial anterior lateral posterior. So that's the medial basal segment of the right lower lobe bronchus, of the right lower lobe. So it's, you know, it is important. The knowing the bronchial anatomy is important, right? So this patient should have bronchoscopy for diagnosis of this lesion. So there is the medial basal segment right there, and it goes right to the lesion. So that would be easy for the bronchoscopist to get a nice sample of that lesion there. Okay? What do we think of this case?
Right lower lobe mass.
There's a right lower lobe mass.
To the left atrium.
Yeah. So,
Very vein.
okay, so there's extension into the left atrium. So how does a lung cancer get into the atrium? It can go through the pulmonary vein or around the pulmonary vein. So on echocardiography, of course, they're only going to see the lesion in the left atrium, right? They're not going to see the lung tumor. So actually, lung cancer invading the atrium is probably more common than myxoma. So any patient with a tumor in the left atrium, you want to make sure that it's not something invading into the left atrium from the adjacent lung. So lung cancers can't do that. Okay. Here's an example of lung cancer invading the left pulmonary artery. Okay, so lung cancers can invade blood vessels. When you're dealing with advanced lung cancer, you know, go through the things to look at, the tumor itself, describe the tumor, but also don't forget, look at the airways, look at the pulmonary arteries, look at the pulmonary veins. In this case, there's an extensive, big, large infiltrating neoplasm there in the right lower lobe, extensive mediastinal lymphadenopathy. When you look at the airways, you notice the bronchus intermedius is completely squashed, so that's something you want to mention. You want to go back and look at the pulmonary arteries. Here's the right pulmonary artery coming down. The interlobar pulmonary artery goes down kind of into the tumor. You also want to look at your pulmonary veins. And in this case, we can see the left inferior pulmonary vein very nicely, but the right inferior pulmonary vein is also encased with tumors. So as we follow that down, look for those there. The right inferior pulmonary vein, we really can't see that very well. So make sure that when you're done talking about the cancer and everything else, go back, look at the airways, look at the pulmonary arteries, look at the pulmonary veins to be able to talk about those and what effect the tumor is having on those structures, okay? So, how do you interpret these changes here in the right upper lobe? This is a patient with a lung cancer causing atelectasis. And how do we interpret these changes here in the right upper lobe in this case? First of all, how would you describe this?
Ground glass opacity.
This is ground glass. What is this stuff?
Septal thickening.
Yeah, there's interlobular septal thickening in the right upper lobe in this patient with lung cancer. So how do we interpret that?
Lymphangitic spread.
So one concern is lymphangitic carcinomatosis, right? So certainly lung cancer can give you lymphangitic carcinomatosis. The classic appearance of lymphangitic carcinomatosis is what?
Nodules.
Nodular thickening of interlobular septa. Is this nodular or smooth? This is pretty smooth. Now, lymphangitic carcinomatosis can give you smooth thickening also, so that is still a consideration. But what else might give you smooth thickening of interlobular septa like this in a patient with lung cancer localized to the right upper lobe?
Venous obstruction.
Venous obstruction, right. So what would be obstructed?
The right upper pulmonary vein.
Right upper lobe pulmonary vein. So lung cancer, if it obstructs the pulmonary vein, can cause localized areas of interstitial edema. So you can get localized areas of interstitial edema, interlobular septal thickening with lung cancer if it obstructs the pulmonary veins from that area. All right. This cancer is in what lobe?
Right lower.
What?
Right lower middle.
I see. Well, on the lateral view, we can see the tumors back here. So most of the tumor you might say is where? Certainly,
Right lower.
right lower lobe, okay? So there's the tumor here, so here's the tumor here. So if this patient is a surgical candidate, what does the surgeon need to know about this tumor? So, yeah, it crosses the fissure, right? So this is right lower lobe, so here it is crossing the fissure, it looks like probably going into the right middle lobe there. What's the significance of that, if the tumor is crossing the fissure?
You have to take out 2 lobes.
Yeah, so a lobectomy is not sufficient, right? So if a tumor crosses the fissure, then the adjacent lung is involved. That does affect the surgical approach and what the surgeon is going to want to do. So if a tumor is next to a fissure, you want to look to see, is the fissure being crossed by the tumor? That's important information that belongs in the report. Patient with lung cancer, what do we have? Adrenal mets, right. So it's important in your protocols for lung cancer to image all the way down to the adrenal glands. The adrenal glands are a common location for metastatic disease for lung cancer. So you have to scan all the way down to the adrenal glands in all patients with lung cancer. You should scan all the way down in all the chest protocols anyway, just in case. What's unusual about this adrenal? Big and what else is really unusual? What? Bilateral, but
It's involving both adrenal glands.
yeah, but lung cancer can do that. That's not unusual. It's going into the IVC. This tumor is invading into the IVC, right? Most common tumors to invade into the IVC, usually renal tumors, but adrenal tumors can do that also through the adrenal vein. So this tumor is invading into the inferior vena cava. So that's kind of unusual for an adrenal med, right? So this patient is having a routine follow-up CT for lung cancer, right? So the patient comes into the outpatient center and gets their routine follow-up CT for lung cancer. Of course, we can talk about the mediastinal nodes, we can talk about the primary tumor, but there is another important finding in this case, and I would tell you to look carefully at the blood vessels. And what do you notice?
There PE.
Yeah, so there's PE where?
The right.
Yeah, in the
lower-
right lower lobe. Okay, so this is not a PE protocol. The patient did not come in for a PE scan. So there is, if we follow the interlobar artery down, we got segmental PEs there in the right lower lobe. So in outpatients with PE, the most common scenario is patient with a cancer. So remember, cancers increase the risk for PEs. They make the patients hypercoagulable. In all outpatients with history of malignancy, look, when you're scanning the chest, look very carefully at the pulmonary arteries. These are patients where you might pick up relatively asymptomatic pulmonary emboli. They will still treat the patient for PE, if you find PE on these patients. but look carefully. These are not P protocols, right? What'd you say?
Is there some in the left lower lobe segmental brain?
So let's see, follow it down. Left lower lobe.
Oh,
Yeah.
yeah.
Okay. So, very important, look at the pulmonary arteries in all patients with a history of cancer. This patient was transferred to this hospital because at an outside hospital they found this brain tumor. And so he was transferred here for a biopsy of this brain tumor, and they get a pre-op chest radiograph before the biopsy. What are you going to say? There's a left upper lobe mass, right? Remember that mets to the brain from lung cancer are more common than primary brain tumors. So if we get a history of patient with brain tumor and you're looking at a chest x-ray, make sure you're not missing a lung cancer. Okay, so this is a patient with lung cancer that metastasized to the brain, all right? And the only reason somebody might show you a bone scan and a lecture on lung cancer is, well, one reason might be bone mets, but are these bone mets or is this something else?
Maybe the pulmonary osteo.
Yeah. So pulmonary osteoarthropathy, right? So you have these areas, the cortices here there's increased activity here in the cortices of the lung bones. Lung cancer can be a cause of that, a pulmonary osteoarthropathy. Okay, so that can be associated with lung cancer. All right. And we'll start with staging. With lung cancer, a few words on lung cancer staging. Yet again, they have changed or upgraded the staging system. It made it even more complicated. But the point of staging, why we do this, is that it determines the prognosis. First of all, you can see what the 5-year survival is for these different stages. But it also determines what protocols patients are eligible for in terms of treatment protocols. So when you're doing tumor board, determining the staging is an important thing because it essentially determines what treatment options are available for the patient. You'll notice that there is a difference between clinical staging and pathologic staging. So clinical staging is the staging based on imaging. Pathologic staging is based on the actual biopsy results. And you'll see that the survival tends to be better. The 5-year survival is a little bit better for pathologic staging there. So why is that?
It's more specific?
Well,
Better assessment of invasion?
yeah, in a sense, but it's essentially lead time bias. Because what you're doing is you're finding, if they have actual lymph nodes to examine, when we say the lymph nodes are involved when they're enlarged or abnormal activity on PET, they say the lymph nodes are involved if there's microscopic disease. So pathologic staging tends to upstage the patients. And so there's a lead time bias there, and that's why there will be that discrepancy. Now, as far as the T descriptors, again, it gets very complicated. What I'm going to go over is things that you can remember so that you should be able to handle any questions that come up on exams as far as staging. So if you remember the numbers 3, 5, and 7, so we'll start there. So T1 less than or equal to 3, T2 3 to 5, and then T3 5 to 7, T4 greater than 7. So in terms of size. But the other important thing is the distinction between T3 and T4. T3 tumors are advanced tumors that involve resectable structures. So if it involves the parietal pleura, the chest wall, phrenic nerve, the parietal pericardium is resectable. So those are considered resectable structures. So that's T3. T4 tumors are usually unresectable. So that's a dividing line between T3 and T4. So these tumors can involve unresectable structures. So if the tumor extends to the mediastinum, the diaphragm is considered unresectable. The myocardium, the great vessels, the trachea. Think about the midline, the heart, the trachea, vertebral body, esophagus, carina. Involvement of any of those makes the tumor T4, and generally those are unresectable. All right, so that's an important distinction between T3 and T4. N is easy to remember. So N0, no nodes, N1, ipsilateral, up to the ipsilateral hilum. N2 up to the ipsilateral mediastinum. But N3, whenever you have contralateral or supraclavicular lymph nodes. So contralateral, mediastinal, or hilar nodes makes it N3. The difference between N2 and N3 also is important. N3 is usually considered unresectable. So up to N2 can be resected, but N3 is usually considered unresectable. All right, so that you can remember. As far as the M descriptors, this is relatively straightforward. M1A, if you have intrathoracic Mets, malignant pleural effusion. M1B, single distant metastases. M1C, multiple distant metastases. All right, so that's relatively straightforward. Is an example of a malignant effusion. So there's the lesion there. You can see that when there is a pleural effusion associated with neoplasm, you have to look at the pleura very carefully, because sometimes the thickening can be pretty subtle, but it's easy to see on the PET scan. You can see the areas of abnormal activity on the PET scan pretty easily there. Okay. So I'll tell you that this is a non-small cell lung cancer. There's no lymphadenopathy, no metastases. Is this tumor resectable? First, what is the tumor doing?
Invading into the pleural wall.
Yeah, well, it's gone beyond the pleura. It's invading the chest wall. So is this tumor resectable?
No.
The chest wall is resectable.
Yeah.
So this is T3, right? So the chest wall is considered resectable. The ribs are resectable. So that is a T3 tumor. That is resectable. It turns out this is T3N0, M0, stage 2B. That is a resectable tumor. Okay. So what are signs that a tumor is unresectable? Signs of T4 lung cancer. If it involves the trachea carina, more than 180 degrees of these vascular structures, if it extends into the mediastinum, if it involves the vertebral body. Malignant pleural effusion makes it M1A. That also makes the tumor unresectable if you have that. Although you have to prove that the effusion is malignant, make sure it's not a reactive effusion. Okay? Is this resectable? What is the tumor doing?
Abutting and maybe encasing a pulmonary.
Is it abutting or doing more than just abutting?
It looks like it's encasing.
Well, it's right up against it, and there's some irregularity along the wall of the pulmonary artery, right? So here we'd be concerned about invasion of the main pulmonary artery. So is this resectable?
No.
No. So that tumor is also unresectable, okay? Lymph nodes. So on CT, we described lymph nodes based on the size. So here we have, this is a lymph node bigger than a centimeter there in the mediastinum. What am I pointing to here? What is this? What's that big opacity here? What is that?
Is that atelectasis?
Yeah, so that's atelectasis. Why is there atelectasis there?
It's a lymphadenopathy? Like leading to obstruction?
Can you do better than that? Why is there atelectasis?
Endobronchial lesion.
Do you see an endobronchial lesion? There's an endobronchial lesion right here, left upper lobe bronchus. There's an endobronchial lesion with post-obstructive collapse here, right? So there's atelectasis there. Here's your endobronchial lesion, right? So here are lymph nodes in the mediastinum. How confident are you that these lymph nodes contain tumor? What is the positive predictive value of CT? Is it 80%, 90%, 100%? How good is CT at predicting whether lymph nodes are involved with tumor? Good or not good?
80.
So we have one vote for 80%. Okay. Well, on this, it turns out on CT, all we have is the size, right? So hilar nodes usually up to 7 millimeters, mediastinal nodes up to 10 millimeters. Well, when we're just looking at CT, all we have to go on is the size of the nodes. There are other causes for lymph node enlargement besides involvement with neoplasm. They can be reactive nodes. There can be other diseases like TB sarcoid that can also result in enlargement of lymph nodes. This is an old study, but here they looked at lymph nodes pathologically when they were resected at the same time as the tumor. 37% of nodes, 2 to 4 centimeters in size, those are big nodes, associated with lung cancer were hyperplastic and free of tumor. You can also have normal sized nodes with microscopic foci of tumor. Those nodes are going to look normal on CT. So how good is CT? For staging, the positive predictive value of 56%. It's like flipping a coin. So CT by itself is not very good for determining if lymph nodes are involved with tumor. That's why we use PET. Right. That's why we use PET. These turned out to be reactive nodes. They were not involved with tumor. Right? So PET, this patient, you can see the lymph nodes here on the opposite side of the tumor. This is N3 disease, right? So you can see how PET shows you the activity there within the nodes. There's the activity within the tumor. What's the significance of N3 disease?
Non-resectable.
Unresectable, right. N3 disease is unresectable. So there's your sensitivity and specificity for PET. If there are findings for distant disease, especially if that's going to change the management, if you're going to deny surgery to the patient because of findings on PET, like contralateral lymph nodes and N3 disease, it is important to confirm that histopathologically before you deny the patient surgery. Okay, because surgery is considered really the only curative option for lung cancer, although, you know, the other treatments are getting better and better. But before you, you know, before we decide the patient is not a surgical candidate based on the extent of disease, you'd want to confirm that histopathologically. Now, I've given you this also when you're reading the CT scans, especially for the oncologist, especially for staging the patient. There are these lymph node stages, these lymph node stations that are actually numbered. Okay, and giving you this nice chart with all the lymph node stations. I don't expect you to memorize this. Okay, but if, you know, when you're reading the studies, sometimes the oncologist will want to know which stations are involved. That does determine the staging and, you know, what they're going to do. Also, it determines, you know, what nodes are accessible by mediastinoscopy for these patients versus transbronchially, right? So that's also important. Here's a nice example where we have a para-aortic node there. Subaortic is the same as aortopulmonary window. That's this guy over here. Paratracheal, this node over here, adjacent to the trachea. So para-aortic here, aortopulmonary window, left paratracheal. What's the difference between paratracheal nodes and aortopulmonary window nodes? How do you distinguish between paratracheal and aortopulmonary window nodes? You see the answer right there.
What side it's on in relation to the,
In relation to what? What is this guy?
that's the.
Ductus
yeah, the
arteriosus.
Well, it's not the ductus anymore, it's the
No,
ligamentum arteriosus. Right. So lymph nodes that are medial to that or paratracheal lymph nodes that are lateral to that are considered AP window. Okay. So evaluation, chest X-ray, chest CT with contrast, PET CT if we're thinking especially about whether or not the patients are going to be a surgical candidate, but also for staging the patients. You might biopsy mediastinal nodes for stage 2 tumors. Again, if you're going to offer surgery, you know, you don't want to do surgery if it turns out they have contralateral lymphadenopathy. So if PET lights up, then you want to confirm histopathologically that those nodes are involved with tumor before you deny the patient surgery. Okay. And then the stages. So once you've decided what the T stage is and the N stage is, you can go to the chart and then figure out what the overall stage is for the patient, so that you can also do it. All right. So this is a 26-year-old man with a lung mass. Very large mass over here, okay? And here's the appearance on CT. What's the difference between the left and the right?
Contrast.
Yeah, so we have good contrast there on the right. The left is non-contrast. Now, certainly, young patients can still get bronchogenic cancer, so that's still in your differential diagnosis. But is there anything else that should be in your differential diagnosis? So you have this large mass in this 26-year-old. What could this be?
TB.
TB
Infections?
usually, well, infections usually don't give you masses that are quite this large. I suppose there are case reports of that, but usually not so big. Also, what's the difference between the non-contrast and the post-contrast portion? What's different about the lesion?
It's enhancing.
It's enhancing, right?
Mm-hmm.
So are you worried this is neoplasm, or
Yeah.
yeah, you're more worried that this is neoplasm given that degree of enhancement? Is there anything else you might consider for this patient?
Besides neoplasm.
No. What kind of
Oh, okay.
neoplasm? besides bronchogenic cancer?
Carcinoid.
Carcinoid tumor, right? There's another class of lung cancers, it's carcinoid tumors. So think about those in younger patients, also in patients who have no history of smoking, if there's a lung mass, right? One clue that it's carcinoid, well, there are a couple of clues that it's carcinoid. What are the clues that it's carcinoid?
It's strong enhancement.
Yeah, so it's enhancing, right?
Calcification.
Like calcification.
Calcification, what else? It's obstructing an airway. See how close it is to an airway. Okay. Neuroendocrine tumors also, malignant neuroendocrine tumors can also have a similar appearance. They can also enhance, right? And they can also be quite large. What am I showing you here on this chest radiograph?
This is the finger and glove sign.
Yeah, so there's a branching tubular opacity here, right? So that's a finger and glove sign. So what's the significance of the finger and glove sign? What does it mean?
Usually like a bronchoseal.
So mucoid impaction, right? So this means that there's mucoid impaction here. So give me two benign causes of this and one malignant cause. What are benign causes of mucoid impaction and finger and glove sign?
Mucus plug?
What?
What a mucus plug?
Mucus plug from what? Well, what underlying disease?
ABPA.
Allergic bronchopulmonary aspergillosis, right, if the patient is an asthmatic. And is there a congenital condition that's associated with mucus plugging?
Cystic fibrosis?
What?
Cystic fibrosis?
Cystic fibrosis can, although that's usually more extensive, it's not localized.
Like a ciliary dyskinesia? Like
Ciliary,
heart
well, ciliary dyskinesia, again, is kind of like cystic fibrosis, gives you widespread abnormality. And then that tends to be at the lung bases, interestingly, while asthma, not asthma, but cystic fibrosis tends to be uppermost. Congenital bronchial atresia, right, that can give you a focal area of mucoid impaction also. Malignant cause,
The bronchial lesion,
like,
bronchogenic carcinoma,
not so much cancer, why?
or excuse me,
Cancer tends to be more aggressive, right? So you want to think of a slow-growing endobronchial tumor, which would be
carcinoma?
carcinoid, right? So carcinoid can cause mucoid impaction. In this particular case, what's the clue that this patient has an endobronchial tumor? Well, what is this attenuation?
it's fluid attenuation,
Which is what you would expect with
mucoid
mucoid impaction. What's happening here?
Oh, is that like?
Some sort of attenuating lesion, or enhancing lesion.
So patient was given contrast, so there is enhancement, right? I mean, to be sure there's enhancement, you want a non-contrast CT to prove to you that that is actual enhancement, but if there's an enhancing endobronchial component, then we like carcinoid for this, right? What if it looked like that on non-contrast CT? What would you think about? What if it was hyperdense like that on non-contrast CT? That's not enhancement. What would it be? Well, what gives you high attenuation
Calcium.
mucoid impaction?
Oh.
ABPA. ABPA can also, the fungus can have ions in it, metallic ions that gives high attenuation. That can also give you high attenuation mucoid impaction. Then a year later, this thing got even larger. All right, so that was a carcinoid tumor. So carcinoid can't present with atelectasis or mucoid impaction. We think of it, we include it in our differential of an endobronchial lesion. We're discussing carcinoid. So it arises from neuroendocrine cells, can produce serotonin, ACTH, bradykinin. 3 types, typical carcinoid, atypical small cell, as you go along the spectrum of how aggressive these tumors are. So the typical carcinoids arise in main or lobar or segmental bronchi. They're not always benign. They can have metastasis in up to 15% of cases. The bulk of the tumor might sometimes be outside of the of the bronchus itself, so that's called the iceberg side if there's a big soft tissue component actually outside of the bronchus. Okay, so here's an endobronchial lesion with marked enhancement. There's complete absence of left upper lobe, so there's a left upper lobe collapse in this case, nice Lufsical sign. So this is a carcinoid tumor. Atypical carcinoid, somewhat more aggressive, so this one here has some mediastinal lymphadenopathy, 40 to 50% metastatic disease. Again, think about these tumors if you have a lung mass in a young patient or a patient who's not a smoker. So this was a middle-aged woman who had a tumor here, no smoking history, that turned out to be an atypical carcinoid tumor. So you can include that in your differential. What do we notice about this lesion?
It's calcified.
What about the calcium? Is that a granuloma or is that something else?
No, it's not central, so it's less likely to be
Yeah.
a granuloma.
So the fact that it's eccentric calcification means that you do have to think about neoplasm now in your differential diagnosis if you have eccentric calcification. And what neoplasm do you think this was?
Is it carcinoid again?
This is also carcinoid, right, arising next to a bronchus. So these central carcinoids can be associated with calcification, especially eccentric calcification, and they can also arise next to an airway or involve the airway. So that appearance is also described with these central carcinoid tumors. They can have eccentric calcification. How is carcinoid staged? The same staging system that we use for lung cancer. So the staging system is the same. Nothing new that you have to learn there as far as the staging. Here's a 44-year-old woman with shortness of breath. The arrows are pointing to lung nodules, right? And we have mosaic attenuation, and I'm telling you it's from air trapping. So we have this combination of air trapping and small lung nodules in a 44-year-old woman. What could this be? What? You said it. Yeah, so this is a rare disease abbreviated as DIPNEC that stands for diffuse idiopathic neuroendocrine cell hyperplasia. So this represents neuroendocrine cells that are hyperplastic and they can grow around the airways, and so that then can result in airway obstruction and small nodules. So that combination of obstructive airway disease giving you the mosaic attenuation and small nodules in middle-aged women can be this, DIPNEC. If it invades if you have these kind of carcinoid tumorlets that actually invade the basement membrane, then you're getting into actual carcinoid tumors themselves. But DIPNEC is just hyperplasia without marked invasion of the basement membrane. So if there's kind of a spectrum here when we're dealing with these carcinoid type lesions. So pre-invasive would be DIPNEC, low grade, typical carcinoid, intermediate, atypical carcinoid, high grade, large cell cancers, large cell neuroendocrine tumors, and then the highest grade is small cell cancer. So what's unusual on this chest radiograph?
There's the diffuse reticular opacity.
Yeah, so there's reticular opacity. What do you call these?
Curly B lines.
Curly B lines, right. So there are curly B lines here. So it's interstitial opacity, but it's only on one side. So you have this unilateral curly B lines, unilateral extensive interstitial disease. Right? Now, curly B lines, what's the most common thing that gives you curly B lines?
Pulmonary
Vascular
edema.
congestion.
Pulmonary edema, interstitial pulmonary edema. It's more than vascular congestion. It's interstitial pulmonary edema. Can you have unilateral interstitial pulmonary edema? Can you have unilateral pulmonary edema? See, if somebody says
Saying
no,
no.
of course the answer is yes.
Oh.
But how? What gives you unilateral pulmonary edema?
Vascular obstruction,
Of what?
the venous return.
Oh,
Yeah.
pulmonary
So
edema.
if there's a mediastinal process that's obstructing venous return on one side, that can give you unilateral pulmonary edema. What kind of mediastinal process might do that?
Obstructive lesion, tumor,
So a tumor, anything benign? What?
Re-expansion pulmonary edema, maybe?
Yeah, but we're on the category of obstructing the pulmonary vein, right? But you're right, re-expansion pulmonary edema is probably the most common scenario where you're going to see unilateral pulmonary edema is re-expansion, right? But what's a benign process that causes obstruction of pulmonary veins and can only be maybe on one side? That is fibrosing mediastinitis. Okay, so fibrosing mediastinitis can do that. We can have unilateral pulmonary edema from re-expansion pulmonary edema, right? So that's a cause. What cardiac problem can give you predominant unilateral pulmonary edema?
Isolated mitral valve regurgitation.
Yeah, so sudden onset of mitral valve regurgitation. So what's the scenario? Acute mitral valve regurgitation from that causes
Is that heart attack?
rupture of the papillary muscle, right? So that can also result, and that also tends to be on the right side, right? So all of that, those are things that you might consider. Pulmonary embolism, where would the pulmonary embolism be?
Arterial?
Hmm?
Pulmonary or arterial?
Yeah, pulmonary arterial, but where would the clot be in this patient? If this is a PE, where's the clot? So can PE cause unilateral pulmonary edema, and how? Well, if there's a big PE in the left pulmonary artery, that actually protects that lung from pulmonary edema. So contralateral pulmonary embolism can be a cause of unilateral pulmonary edema. On the other hand, if I told you that this patient had a procedure done for pulmonary embolism, what procedure was done and what side was it done?
Thrombectomy on the non-affected side?
Thrombectomy on which side?
The side that does not have pulmonary edema. Oh, no, could be
Thrombectomy
reactive.
on the right side. That causes reperfusion pulmonary edema. Okay, so pulmonary embolism can also be a cause of unilateral pulmonary edema. Those are a couple of ways that could do it, right? So here is the CT scan on this patient. Is this pulmonary edema?
No.
Why not?
I'm looking at it and it's a little, let's see, is it a little irregular, a little thick?
What do you call these?
Oh,
Micronodular opacities.
Those are all nodules, right? And there are nodules here too. Right? So you do have interlobular septal thickening. It's somewhat irregular, but you have all of these nodules, right?
gotcha.
So what are we thinking about then?
I mean, this would be lymphangitic carcinoma.
Sure, lymphangitic carcinomatosis. Lymphangitic carcinomatosis, though, usually gives you bilateral disease. Under what conditions, what are the tumors that can give you predominantly asymmetric or unilateral lymphangitic carcinomatosis? Breast cancer and
Carcinoid, detox carcinoid.
lung cancer. Lung cancer, right? So those two tumors can give you predominant, this was a patient with breast cancer, can give you predominant unilateral lymphangitic carcinomatosis. So what does this represent? So these are when the tumor actually gets into the lymphatics, right? Remember, the lymphatics run in the interlobular septae, so this can be metastatic disease to the lymphatics or retrograde spread from lymph nodes spreading retrograde into the lymphatics. So transbronchial biopsy has a high positive yield, so you can recommend that if you're considering this. So to find these tumors within the lymphatics there, right? Lung cancer, breast cancer might be unilateral upper abdominal tumors, prostate cancer. Those can also give you, these are the common causes of lymphangitic carcinomatosis. What do we see on chest radiograph? You might have interstitial disease, could be reticular nodular pattern, curly B lines, right? Pleural effusions, lymphadenopathy, of course, it's metastatic disease, so you might see that also. But it does tend to give you an interstitial pattern on the chest radiograph. So the Metaport, big clue that this patient has an underlying tumor, reticular nodular pattern bilaterally. And then when we look on CT, we see that there's this interlobular septal thickening that's somewhat nodular. So nodular interlobular septal thickening, usually worse at the lung bases in cases of lymphangitic carcinomatosis. So the lymphatics run alongside the bronchovascular bundles here, alongside the airways, and also run in the interlobular septum, where you see the green there. And so that's where we tend to get these nodules with lymphangitic carcinomatosis, along the airways, along the vessels, and also along the interlobular septum. So we've seen this case of lymphangitic carcinomatosis. Here's a case of somebody with lung cancer, giving you a more localized pattern with this irregular interlobular septal thickening here, limited predominantly to the upper lobe, right? So it's lymphangitic carcinomatosis in someone with lung cancer. So remember that pulmonary edema, which is the most common cause of interlobular septal thickening, should be very smooth. This is nodular. So there we think of something else besides pulmonary edema. This is pulmonary edema, very smooth interlobular septal thickening. Okay. Differential diagnosis, pulmonary edema, that tends to be smooth. Sarcoid silicosis, these can also give you nodular interlobular septal thickening, but there are other findings, architectural distortion, sarcoid tends to be upper lung predominant. Silicosis, you might have lymph nodes, eggshell calcifications. Pulmonary fibrosis also is associated with architectural distortion. With lymphangitic carcinomatosis, you do not get architectural distortion, so you don't get scarring with lymphangitic carcinomatosis. We need to talk about complications of immunotherapy, right? So nowadays, there's all these kinds of fancy immunotherapy that they offer these patients, and many times the abnormalities that we see on follow-up CTs may not necessarily be progression of tumor, but might represent complications of immunotherapy. These tend to occur within the first 12 weeks of treatment. There can be some patterns of pneumonitis. Organizing pneumonia is a typical pattern that tends to give you these peripheral consolidations, like you see here. NSIP can give you ground glass opacities and reticular opacities, again, in a peripheral distribution, sometimes with that subpleural sparing, can be associated with NSIP. Sarcoid-like reaction can occur, that's unusual, but it can look like sarcoid with the interlobular septal thickening, perilymphatic distribution of nodules, even lymphadenopathy. And then radiation recall pneumonitis that we'll also talk about. The take-home message, if you see unexpected opacities on CT in a lung cancer patient, look at the treatment history, right? You might be dealing with a complication of immunotherapy. So especially if you have strange-looking consolidations on these patients. Sarcoid-like reaction, they can have lymphadenopathy, they can have this nodular thickening, and a perilymphatic distribution that's going to be very difficult to differentiate from progression of disease. It might require biopsy. But again, if we see unexpected opacities on CT, make sure that we check the treatment history in these patients. So, patient comes into the ER and has a CT scan, of course, everybody's rule out PE, but anyway, it looks like this. Then we look in the folder and we notice that 9 months prior, the patient had this. So what is this 9 months prior?
Cancer.
Yeah, that's lung cancer, right? And then they come back looking like this. And so the ER wants to know, do we think this is progression of tumor or do we think this is something else? What are we going to say?
Something else.
What do you think the something else is?
It's very, looking at the current study, it's very almost, what's the word, anterior to posterior, like there's this linear, yeah, basically radiation, yeah, that's what I'm getting at. It's like a beam path.
So there's this sharp demarcation. You have a line here. There's a sharp demarcation here, right? So it's very geographic in terms of its distribution. So you're thinking radiation therapy,
yeah,
right? So it's very important to try to get that history. And indeed, this was a patient who had received radiation therapy. And so we're looking at is post-radiation changes in the lung in this patient, right? And then the other thing you can do is actually go look at the radiation field if it's available to you, because the radiation therapists do plan this with imaging, right? And you can actually go and look at the treatment field. So the radiation therapist can send that to you and you can match that up with where you have the abnormalities. And you see that the portal matches up very nicely with where the changes are in this particular patient. So these represent changes from radiation therapy. Okay. the classic appearance of post-radiation therapy, that sharp demarcation. This is the scarred lung in here, traction bronchiectasis, not respecting anatomic boundaries, that very sharp demarcation between involved and uninvolved lung. And there's the fibrosis, loss of volume on that side from post-radiation therapy scarring. So it usually requires at least 40 gray, 3 phases, the latent phase where nothing much happens, then we have acute radiation pneumonitis, and then the fibrotic phase, 6 to 12 months later. This is the kind of the classic time course of conventional radiation therapy. So there are acute radiation changes which occur in the radiation field, mostly ground glass and consolidations, and then later on, once you're out past 6 months, you can start to get evolving fibrotic changes with volume loss, architectural distortion, and bronchiectasis. So the radiation pneumonitis, these consolidations, they can occur 1 to 6 months after therapy, peaks at 3 to 4 months. These tend to occur, well, these will occur in the radiation field itself, and it's from the death of the cells, from what happens to the cells. So here's the tumor here before therapy. After therapy, we can see the radiation, kind of see where the radiation portal was exactly. That post-radiation pneumonitis is where the portal was. Sharp demarcation between the uninvolved and the involved lung. And then over time, that gets smaller and starts to fibrose. You can see there's some volume loss now and architectural distortion on that side. And the opacities can become more reticular because of fibrosis. So here you have radiation pneumonitis, and then a year later now the opacities have gotten smaller, and now we have fibrosis in that region. Another nice example, here's the tumor. 3 months after treatment, you can see both sides of the mediastinum got treated here. You can see the consolidations for post-radiation pneumonitis. And then you can see as the time goes on, they get smaller and smaller and starts to contract. So the abnormalities get smaller and you get more fibrosis as the time course goes forward. So we've seen this, that sharp demarcation between normal and abnormal lung. Here's a nice example as we go through the time course. Radiation pneumonitis conforming to the radiation portal. 5 months later, you can see that the abnormalities are somewhat less. And then 13 months later, we see some bronchiectasis here, where these regions of fibrosis are, and then it tends to stabilize. Once you get out past the year, not much change between 13 months and 20 months. So this was a woman who showed up in our emergency room with a chest x-ray that looks like this. Again, we look at the old study. 1 year prior, there was a tumor here. And so the CT scan looks like this. This is what it was like before. This is why it's got this funny looking field. She had 2 tumors, and they treated all of it with radiation. And so we're looking at all of this post-radiation change. That sharp demarcation between the uninvolved lung and the involved lung is always a clue that patients had radiation therapy. Now, having said that, now there's this high precision dose radiation therapy. As there are the different modes of this. These are the different types, the different terminology that's used. And the idea here is rather than a conventional port where we place this port down, or the radiation therapist places the port down and just blasts everything that's within the port, now the radiation is adjusted so that the ports are adjusted at different angles. And so the idea is to maximize the dose to the tumor itself and to minimize the dose to the surrounding normal lung. So this is going to change things a little bit in terms of what we see. So we don't see that with this type of therapy, we don't see that very sharp demarcation like you would see with the conventional radiation ports. So 3D conformational radiation therapy. Now there are going to be other areas of the lung that can be far away from the tumor that are exposed to radiation. So we might see radiation pneumonitis in parts of the lung that are now far away from the tumor. And so the different colors give you an idea of the radiation doses, how much radiation dose there is to the surrounding lung. The idea is to maximize the dose to the tumor and to minimize the dose to the normal surrounding lung. But you can see the way the ports are laid down. Even the contralateral lung now can have some post-radiation effects within it. So what can happen then is we can have radiation pneumonitis on the opposite lung. So the tumor is here, 3 months after therapy, some of these changes are radiation pneumonitis, but here on the other side, these changes are also from radiation pneumonitis on the other side, okay? If in doubt, you can talk to the radiation therapist, check the radiation fields. The other thing that can happen is with this type of radiation, the fibrosis can continue to evolve for up to 4 years after radiation therapy. So here, 4 months after radiation therapy, you can see the radiation pneumonitis. 4 years after therapy, it can continue to evolve. So the scarring can continue to go on for more than a year. So between 1 year, 2 years, 3 years, and 4 years, there can be changes on your follow-up CT scans. Although the changes, it should not get larger. The abnormalities should get smaller over time. So what are some of the changes that we can see? Well, the modified conventional pattern is where there's that sharp demarcation between the uninvolved lung and the involved lung, just like you would see with conventional radiation therapy. You can get these scar-like patterns where it looks like a linear scar. And then you can get a mass-like pattern where it looks like a mass, and these can be problematic when you're trying to differentiate between recurrent tumor and post-radiation fibrosis. So when you get a mass-like pattern, that can be a problem. So what are clues that you should be thinking about recurrent tumor as opposed to just radiation change, radiation, evolving radiation fibrosis? If there's an enlarging opacity at the primary tumor site, if there's growth over several CT scans, if there's enlargement after 12 months of X-ray therapy, bulging margins, here's an example with bulging margins, loss of air bronchograms, craniocaudal growth, if it grows up and down, right? These are all clues that you're dealing with recurrent tumor. PET is pretty good here. Once you're past the acute radiation phase, once you're more than 6 months out, if there's concern about what you're looking at as recurrent tumor, you recommend PET CT scan. So the tumor should light up, the post-radiation fibrosis should not, okay? So 3 months though, you still have radiation pneumonitis. The PET is gonna be hot. 10 months, all of that cools off. 15 months, it still stays cool. So if you're doing follow-up CTs and you're questioning whether there's recurrence of tumor, recommend PET scan as long as you're past the stage of acute radiation pneumonitis. And the negative PET is a high negative predictive value. But it can be false positive when you're dealing with that acute radiation pneumonitis phase. Okay? Interesting phenomenon, radiation recall pneumonitis. So what happens here? So 5 months after radiation therapy, right, we have the post-radiation changes, no surprise. 7 months after radiation therapy, things have gotten smaller, right, which is what you would expect. But then after this, the patient gets immunotherapy, and then all of a sudden, we get these changes of radiation pneumonitis in the radiation field, but the patient has not had radiation here between this CT and this CT. What does this represent? This is called radiation recall pneumonitis. So what happens is cytokines induced by the X-ray therapy that collect in the area, so they get triggered by the immunotherapy, and that results in radiation pneumonitis coming back in these patients. Okay? Radiation recall pneumonitis. Radiation-induced neoplasm, this occurs many years. So this is a different cancer. So this cancer was induced by the radiation therapy. This is not recurrence of the original neoplasm, but this was induced by the radiation therapy. But the clue here is that it's many years later. It's about 10 years later. So if something pops up 10 years later, then you may be dealing with radiation-induced neoplasm. So it arises within or at the edge of the irradiated area. So here's an example. Tumor here was treated with radiation. There's your post-radiation changes, but something's happening now. 9 years later, this ground glass gets worse. 11 years later, it develops a solid component here, positive on PET. So this is a radiation-induced neoplasm. Once you're out past 10 years, then this is when you start thinking about radiation-induced neoplasm as opposed to just recurrence of the primary tumor itself. Okay. 62-year-old man with shortness of breath. Is the X-ray normal?
No.
No. What does it show?
Bilateral hazy pulmonary opacity.
Yeah, right. So we have these bilateral consolidations. Okay, big deal. But it looks like this on the CT, and here's another image from the CT. First, what are the findings here?
Like cirrhotic.
Right, so the
liver with
patient's a
mass-
cirrhotic, right?
Ascites.
Yeah.
Ascites, right?
Left hepatic lobe, there's
There's
a mass.
There's a mass there, yes. So how do we put these findings together?
Metastasis.
Do metastases give you consolidations with air bronchograms?
Central.
Yeah, look at that very kind of that location of these. Not quite perihilar, not quite at the periphery, right in the middle of the lung. So, patient has a liver cancer, right? What treatments are offered for liver cancer?
Oh, there's Y90 embolization. There's,
What would that do?
Well, let's just say that there was a shunt,
Oh.
portosystemic shunt.
So this is radiation pneumonitis from Y90 therapy.
Okay.
Why that particular location?
Because it's vascular distribution in terms of like.
Yeah, but why would you would think, PEs go to the go to the periphery of the lung.
Yeah.
Why here?
So the size of the beads?
Yeah, that's where they
Oh.
get stuck.
Oh,
That's where they get stuck, right? They don't go all the way to the periphery, they get stuck there. So that's why you can have this pattern, this almost kind of a bat wing pattern of radiation pneumonitis from therapy, from Y90 transarterial chemoembolization. So this can occur 4 to 6 weeks after embolization, right? Associated with a lung dose of greater than 30 gray, and it can give you those bat wing type of consolidations, which is why to decide if the patients are a candidate, they test the lung shunt fraction, they calculate the lung shunt fraction. So they do an intraarterial injection of technetium 99M MAA, and then they scan the patient in nuclear medicine to see how much of it goes to the lungs. If more than 20%, so they're injecting it, into the hepatic artery, right? So if more than 20% of that winds up in the lungs, then that's a contraindication to the procedure because there's a large amount of shunting to the lungs. And so that patient would be at high risk for the radiation pneumonitis. So here it's about 12%, here it's 18%, here it's 52%, and that's calculated based on the amount of activity within the lungs when they inject the hepatic artery with the MAA. So here are some examples. This patient's lung shunt fraction was 23% and developed radiation pneumonitis in the lungs. That's what it looks like in this particular patient, Y90 pneumonitis. Okay. There's a 70-year-old woman, scan immediately after the Y90 therapy, so some activity there within the lungs. There's the tumor, comes back with some radiation pneumonitis there within the lungs. Okay. All right, so that is our discussion of lung cancers and neoplasms, and we will have a quiz next time. Any questions? Okay, see you guys next time.